So it's a big webinar. So we shall now open and review the case. So Dr. Gabriel Gutierrez will present the case now.
Okay, so good afternoon everyone. Let me share my screen. Okay, so good afternoon. Today I'll be discussing a case of an 88-year-old female who has a history of transient ischemic attack last 2011, who was also diagnosed with dementia. The patient underwent hip replacement on the right last 2021. We classified her as equals 1, and she came in with a chief complaint of generalized body weakness. So the history of the patient: 10 days prior to admission, the patient experienced unproductive cough with undocumented fever. 7 days prior, it was already accompanied with abdominal discomfort, vomiting, and episodes of loose watery stools. Few days prior, the patient already experienced generalized body weakness. Hence, the relatives prompted the patient to be brought to the emergency room to be admitted. So, on the day of admission, the patient is awake, follows commands, has a mental examination score of 22/30. No gross facial asymmetry were noted. MMTs were 5/5 in all extremities. No sensory deficits. Vital signs were stable with a slightly elevated blood pressure at 120/80. The abdomen at the time of admission was soft, non-tender, and non-distended, with a noticeable 2 by 2 centimeter defect on the left inguinal area. However, it was non-tender and no discoloration was seen. A CT scan of the abdomen was done at the time. The important finding here was there was a left inguinal hernia noted containing small bowel and a mental fat. Course in the ward of the patient. From day 0 to day 5 of admission, the course was unremarkable. The patient was clinically well. Not until day 6 of admission, the patient complained of abdominal discomfort. Physical examination at that time showed direct tenderness with voluntary guarding. On the day 8 of admission of the hospital stay, the patient was already advised surgery. However, at the time, the patient refused. On the day 9 of admission, an ethics committee meeting was done at 10 o'clock in the morning. And discussion was done from 10 o'clock until around 4 p.m., where we were already trying to secure the informed consent of the patient. The summary of the ethics committee at the time was the neurologist said that the patient was of sound mind and is capable of deciding on her own with regards to the treatment that she will receive. On the 4 p.m. on day 9, the patient already agreed to do the surgery, and 7 p.m. we did the consent was secured, and we immediately performed the emergency surgery. It is important to note at the time the patient already showed signs and symptoms of bowel obstruction, namely unable to pass bowel movement with episodes of vomiting. So we already plan to do the procedure as soon as possible, since we categorize it already as emergency. So for the ethical framework of this case, we divided it into four. This is called also the idea framework. So first is we identify the facts related to the case as well as the stakeholders involved. Second is to determine the problem and the ethical principles or values related to the case. Third is to explore the ethical options for the case. And lastly is to act on the decision, the ethical decision that was made and to evaluate. Okay. So for the first part, we identify the stakeholders involved in the case. So namely, of course, the patient. It is important to note that the patient is alert and judged to have decision-making capacity, namely being able to secure an informed consent without the influence of other people. So at the time, the patient's stand was to refuse surgery. She was for her it was she was clinically well, and she seemed that she think that she didn't need the surgery. So the ethical principle involved regarding the patient is the principle of autonomy. So one of the stakeholders also, the patient has 4 children. So the relevant interests for them, 3 out of the 4 children agreed with the patient's decision to not undergo the surgery. For this, there is no specific ethical principle involved, but we think that the Filipino value of shared decision making is evident regarding the part of the children. So the next stakeholder for the case is the attending physician. So the attending physician, of course, has the decisional authority with regards to the clinical management of the patient. So the physician also believes that performing the surgery is the only option to save the patient from harm. So a number of principles are involved regarding the physician. One, of course, is beneficence. And with that, of course, with beneficence, we want to do no harm. So this is the principle of non-maleficence. Another ethical principle or idea that we can count also is the concept of selective paternalism regarding since the physician is well versed or knows medically what is the best option or the best treatment plan for the patient. So the second part of the framework is to determine the ethical dilemma. So the question arises, how must a surgeon ensure the best interest of this patient who is presenting with an impending bowel obstruction, but at the same time refuses to consent to a life-saving procedure?
Excuse me, Doctor.
Yes.
We have to clarify first. No? You pigeonhole certain things here, and we'd like to see the flow of what happened to this case. Number one, this patient came in with an abdominal pain and cough and was admitted to the hospital. You said the first 6 days was uneventful. So they were just keeping this patient in the hospital without any problem?
Yes, doctor. The chief complaint of the patient at the time was generalized body weakness.
On day 5, there was abdominal pain, and you did CT scan, and what did you find? What's your diagnosis?
On day 6, doctor, hospital stay, the patient presented with vomiting, abdominal discomfort, and unable to pass bowel movements.
What was the diagnosis of the attending physician?
Partial bowel obstruction, doctor. Secondary.
Yeah, you never said that from the beginning, so you're just wondering why. Patient here with a hernia on CT scan, and we have been discussing all of this. Well, because we have to center on an ethical problem, not just discussing medical or surgical options here and how to approach this patient. If we should have an ethical dilemma here, that's why we're presenting it. Okay, you have to build it up to that. So this patient had abdominal pain, and we saw that there's a hernia, and we developed, we thought that this patient was developing an obstruction, right?
Yes, doctor.
So the surgeons were thinking of doing surgery. And three of the children agreed, and one did not agree. Is that what you're saying?
Three of the four children agreed to their mother, the patient.
Yeah, most of them agreed with the mother, and one did not. And
Yes.
the mother has dementia, but the dementia that you still say that this patient can still make a good decision.
Yes, doctor.
Why do you say that?
There was also a
Your evaluation.
yes, doctor. There was yes, doctor. There was the neurologist on board with this case and present also during the ethics committee meeting held at the time.
Why did you bring this to the ethics committee? What was your problem?
The problem at the time was to whether or not the patient is of sound mind to sign the informed consent on her own. Since the patient
the function of the neurologist who said that this patient is competent enough to do that.
Yes.
Okay. So please proceed. Please proceed.
Okay. So this is the second part of the framework, again, is to determine the dilemma. So how must a surgeon ensure the best interest of this patient presenting with impending bowel obstruction but refuses to consent or to give an informed consent to a life-saving procedure? So we explore the possible options regarding the case. One is to engage the patient and family in active dialogue with the goal of arriving at a mutual understanding or to agree with a treatment plan without abdicating professional responsibility. Another option is that to respect the patient's autonomy of refusing the life-saving surgery. Okay, so the fourth part of the framework is the action plan. So, of course, we invite an open communication among all stakeholders. So we talk to the patient as well as the children, and to seek the extent of their understanding regarding the case, and also to explain to them as simply and as cohesive as possible where the patient is at now. We also implement the plan from finalizing the decision, of course, and implement through securing an informed consent, making sure all the logistics of the case are fixed, to do a preoperative assessment and clearance, and finally to perform the surgery or the procedure. Okay, so for the summary of the case, it is important, the concept of shared decision making is important here. We defined it as an active dialogue between the physician and the patient, so basically the stakeholders involved. The physician expertise also comes hand in hand versus to respect for the patient's autonomy regarding to decide on whether or not to go perform the procedure. So another concept here in this case is the informed consent. So here are the criteria that should be met regarding informed consent. One, the patient must be competent. He or she must receive the full disclosure of the the procedure or the plan. Third is he or she must comprehend the disclosure that will be discussed. Fourth, it should be voluntarily without coercion. And fifth, he or she must consent to the proposed action. Okay, so this is a sample diagram I lifted from an article about selective paternalism. So as you can see here, the clinician is involved with the following concepts like standard of care, medical knowledge, evidence-based medicine. So with the information gathered from the clinician, it will be filtered out with namely the ethical principles like autonomy, beneficence, non-maleficence. The clinician's information hand in hand with the patient's information, together with the ethical principles as previously mentioned. From there, we will get the informed consent of the patient. From the informed consent, we decide, we implement, and finally, we see the necessary outcomes or the final plan for the patient. Okay, so this is my take-home message. So of course, patients has their own right or is entitled to have decision-making capacity. And I think as physicians, sometimes we pride ourselves on respecting patient autonomy and the involvement of patients in the decision-making process. However, we overlook or we sometimes uh, uh, be involved in the concept of selective paternalism and fail to use it appropriately or consistently. So I think as physicians, we should be cautious and conscientious about our decision making. It should be in the best interest of the patient and the quality of life. We should also acknowledge how we make decisions, most especially since there are other lives involved, and we should be responsible for ensuring the highest standards of ethical practice at work and to embrace our decisions in terms of ensuring the best interest for the patients. Okay. So here are my sources for two journal articles. Yeah.
Thank you, Doctora, for that discussion. So, so we put this together. What we're saying is there's this lady who is demented, who came in because of cough and body weakness, who admitted into the hospital. And the first 5 days was no better, nothing. And then on the sixth day, there was abdominal pain. We saw that there was say, hernia, and then on the CT scan showed possible extraction. So in this patient, the discussion with the surgeon on board, the surgeon said, we need to operate on this patient. having said that, the patient disagreed. She said, no, I don't want surgery. And the other children said, yes, we will support Mama. She can decide for herself. And we had a neurologist on board who said, yes, she is competent enough to make her decision on this matter. They heard that. And then one child said, no, you have to operate in save her and get her out of this problem. So when we had a problem of non-agreement between the siblings and the patient himself, and the patient from doubts if you should follow her, was she competent enough, although the neurologist is saying she's competent, he brought this to the ethics committee. The ethics committee says, well, she's competent, and follow what yes, and we discuss this and find a solution that we can have a consensus of everybody. And the situation is mobile, it's not stagnant, and continue to discuss and see what will happen. So that was you say that this discussion is all about informed consent.
Yes.
The question is about informed consent. So
Yes.
the ethical problem here was that there's a patient who is demented, who can still decide, and we have several of our children agreeing with her and one with her not. So having this situation, you think that this is your ethical dilemma and whom to follow. And we were talking about many things: paternalism, consent. So paternalism is no longer involved at this time. And as you can see, we're all discussing about autonomy and informed consent, etc. So I just want to set up what you wanted to discuss. What you were discussing here is a discussion on autonomy and informed consent, right?
Yes, doctor.
Okay, so and we did a process flow. We made boxes and process flow about making a decision making and to find a consensus so that you can do a meaningful decision and be able to follow it, right?
Yes.
That was the process flow. We even made charts about it. Okay? So, what eventually happened to this patient? Did you for a surgery, or did you send this patient home well and improve the medical treatment? What happened?
Yes po. So the patient finally agreed to perform the procedure. And the same day we scheduled the procedure. Then after intraoperatively, we saw that there was part of the part that was herniated was strangulated bowels already. So we resected that part and we anastomosed the bowels. We placed also a mesh to repair the defect. So post-operatively, the patient was clinically well. She was able to eat and no vomiting, fast plateaus, bowel movement, able to walk, and eventually we sent her home clinically improved.
Okay. And having said that, we will now open the floor for questions and clarifications and I'd like to know what happened. Yes, so for the audience, do you have anybody who would like to ask some questions? Raise your hand. Anything clear? Do we have the neurologist on board? Who was your neurologist?
I'm not sure if the neurologist is here for doctor.
If there are no questions, you're done with your discussion, Doctor.
Yes, doctor.
If you're done with your discussion, now The next part will be we will have to introduce our reactors, and we have two reactors. I will introduce them already, both of them, and they will do their reaction one after the other. The first reactor is Dr. and attorney Rodel Capuli. He obtained his Bachelor of Science in Medical Technology at the Adventist University of the Philippines, Doctor of Medicine at the Manila Central University, and Juris Doctor at Arellano University School of Law. He is a diplomate of the Board of Internal Medicine, a Fellow of the Philippine College of Physicians, Fellow of the Philippine College of Emergency Medicine, and a Presidential Awardee of the Philippine College of Physicians. At present, he is a consultant in the Department of Emergency Medicine, Department of Internal Medicine, and Legal Medicine at the Adventist Medical Center, Manila, and consultant of the Department of Internal Medicine and Legal Medicine at Makati Medical Center. He also practices medical practice and physical injuries from 2002 up to the present. Legal consultant at Makati Medical. He is a professor of law and legal ethics, problem areas in legal ethics and legal medicine in Arellano University School of Law, and of course, counsel at the Toledo and Clemson office. So that is Dr. Attorney Rodel Capuli. The second reactor will be a good friend from the University of Santo Tomas, Dr. Gerard Moral. He is a doctor of medicine from the University of Santo Tomas, an associate professor and immediate past chairman of medical ethics of the UST Faculty of Medicine and Surgery. He is a fellow and past president of the Philippine College of Chest Physicians and Philippine Society of Sleep Medicine. He has been our guest speaker here for many of these run rounds and many of our seminars. So the second reactor is Dr. Patrick Gerard Moral. So having introduced them, we now call on Dr. Capuli.
Can you hear me?
Yes,
Good afternoon, sir. Good morning. Good afternoon, colleagues. I have a prepared slides. These are very short slide presentation. Okay. I have the next slide, please. Next slide. Okay. Since we are on the topic of informed consent, I just want to reiterate the recognized exceptions. Our default is to always secure an informed consent before an intervention. Number one is public health emergency. Next slide, please. Okay, public health emergencies. Full disclosure, since we have a personal experience with this during the pandemic, a full disclosure is not necessarily given, in a traditional way, because of the logistics and the police power of the states, which is meant to benefit all, or for the general welfare of the population. So those are exceptions. Next slide, please. Medical emergency. Consent is often implied in emergency medical cases. And when the patient is incapacitated or there are no surrogate decision maker available, then we dispense with the duty to obtain informed consent. Just a word of caution, therapeutic intervention is sometimes not synonymous with emergency treatment. So we must satisfy the legal requirement of what is an emergency before we can invoke the exception. Next slide, please. When we have an incompetent patient, whether from the legal standpoint or really from a physical standpoint. So, strictly speaking, informed consent applies only to legally and mentally competent individuals. So if you don't have a legally and mentally competent patient, So we cannot really say that the concept of informed consent is operative. So if the person is incompetent, then we assign a surrogate decision maker as somebody who can agree to the suggested procedure. Next slide, please. We also can dispense with the informed consent if the patient exercise his right to waive it. No? So, sabi ni pasyente, hindi na ho, okay na ho, huwag niyo nang sabihin sa akin yan. And I think the big challenge really is when the patient will appoint the physician. Kayo na po bahala, doktor. No? Tiwala po ako sa inyo. Alam ko naman pong gagawin niyo po lahat ang mabuti sa akin. So, huwag na ho niyo kung bigyan ng mga concept, o yung mga risks and benefits. Okay na ho sa akin. Basta ho kayo na mag-decision niya. Okay, next slide, please. Then, common knowledge. The law will not, or the court will not, required an informed consent if the risk involved in the procedure is known to an average sophisticated person. So, alam na ng ordinary person. Next slide, please. Then, patient knowledge. A classic example is if the patient underwent the same procedure years ago, the law or the courts may not require, paano alam na yun ng pasyente. But in terms of risk management, we always go through it, But from the legal standpoint, pwede nang makalusot na wala, Because the patient already knows the risk involved, or the valid requirements in informed consent. Next slide, please. Then we also have this concept of therapeutic privilege. Very rare indeed for us to invoke this, but sometimes it is recognized by law. The disclosure of information itself should pose serious and immediate harm to the patient, such as prompting suicidal behavior. That's an extreme example, but that's the idea. If it is something that will harm the patient, then we can dispense with the informed consent. Next slide, please. Okay, so why do we go for a consent form? The consent form simply memorializes the process of informed consent. So if we are able to present a signed informed consent, there is this rebuttable presumption. Again, in law, if you sign a consent form, there is this presumption that you understood the process of informed consent and it has satisfied the requirements. So, rebuttable presumption. But on the other hand, we often say, when it comes to litigation, even if the person signed an informed consent 100 times, it does not readily establish that you have satisfied the legal requirements. Paano nga? Presumption lang yun. If I can present a rebuttable evidence or a contrary evidence to that effect, then I might be able to convince the court that the doctrine of informed consent was not satisfied. Next slide, please. Next slide, please. Okay. Let's talk about some issues when it comes to informed consent. A valid informed consent depends not only on the written consent document, but also to the actual discussion. As I've said, you can present to me a form, purportedly an informed consent form, and yet I might be able to convince the court that you have not satisfied the the legal requirement, because a valid or legal informed consent involves evidences that I have actual discussion with the patient, ano? Hindi lang pirma-pirma. And I've seen it happen. Several hospitals, I have witnessed it. The doctor will only ask the resident, oh, schedule mo yan bukas, papirmahan mo yung form, no? Ganun lang gagawin. But actually, it's really an actual discussion. Many people, including physicians, think that the consent, to treatment is only a form of document. It is a process also. Informed consent to treatment by a patient may be in verbal form, and the court said that is just as valid, depending on the circumstances of the case. When the patient signs the form, it only means that you have reached the culmination of the process. Yun na yung final act, giving the authorization. Okay, next slide. Once the patient has agreed to a specific course of treatment, the process is over. Delegated duty to secure an informed consent may not satisfy the legal requirement. And why is that? Again, I've seen it happen. The doctor will ask the senior resident or any resident, okay, secure the informed consent. Right away, two issues will arise. Number one, it is a process. It is not merely signing a form. And second, the law requires that the one giving the information must be a skilled and competent physician, and that is of course, the attending physician. So that is a requirement, and also it must be given in lay language. The communication. Again, in one case, the court said merely stating the risk in terms of percentage, mortality, morbidity did not satisfy the legal requirement because ano ba ang malay ng pasyente sa mga mortality risk or rate, etc., complications. Sabi ng court, hindi pinasatisfy yung legal requirement. Okay, next slide please. Patient's autonomy and prior family members. In our culture, palaging kasama yan. I consult. And one author said, the decision of the patient to refer it to family members before making a decision is part of his or her autonomy as a patient. Yun ang kanyang gusto eh. We cannot tell the patient, hindi na ako kailangan, competent naman kayo eh. Kaya na competent, yun ang kanyang exercise of autonomy as a patient. So, mag-consult siya, hintayin niya. And this happens more often in cases wherein ang gagastos yung family member. A senior, or let's say a mother or a father, retired, ang gagastos yung family members, he always defer to the decision of the family. Kasama yun ng exercise ng kanyang autonomy. Next slide, please. So, what happens now when a patient refuses the treatment? Simply accepting the refusal. Ayaw ng pasyente. Again, I said, I've mentioned this time and again, Sometimes we as doctors are so fixated with consent and refusal. Basta may consent, game na. Basta may refusal, okay na yan. Papirmahin mo, okay na ako, wala na akong gagawin. Simply accepting refusals in the name of respecting autonomy would be highly problematic. Physicians should listen to patients, educate them, and try to persuade them to accept beneficial treatment. Kung yun naman tatakutin yung pasyente, that might be interpreted as coercion. Or negotiate a mutually acceptable compromise. If disagreement persists, the patient's informed choices and judgment of his best interest should prevail. Next slide, please. Okay, the concept of respect for autonomy and patient's best interest presents two conflicting ethical guidelines, for obvious reasons. We want to respect the autonomy, but we also want what is best for the patient. Minsan magkakontra yun, That's why itong patient's best interest dyan minsan, we are often accused of paternalism. Ito maganda sa kanya, dapat yung masunod. Dapat ako masunod. Ako po ang doktor, diba? So, that must be balanced. But I also mentioned that a good dose of paternalism will do good, for a doctor because in-emphasize mo yung what is best for the patient. Huwag naman ma-overdose kayo ng paternalism. Okay. Another thing is when a patient's decision-making capacity, when a patient agrees to a recommended treatment, wala tayong problema. Right away, kung competent naman yan, sang-ayon yan, then wala nang pag-uusap. Sometimes this thing happens. Next slide, please. Not a basis to hold the patient incompetent. When the patient, pabago-bago ng desisyon, patient vacillated in the result. Fluctuations in mental lucidity, irrationality of decision to reject proposed treatment, Doc, pasensya na po kayo. Paano? May nagsabi sa akin, pag add number, medyo malas daw ho yan. I-postpone na lang po natin. So, these are not considered as a basis to hold the patient incompetent or to question their capacity, yung mga ganyang situation. Next slide, please. Under our law, the burden is to prove that a person is of unsound mind under Article 800 of the New Civil Code. The law presumes that every person is of sound mind, in the absence of proof to the contrary. That's why we call this rebuttable presumption. But the law operates in a way that the law treats an adult person or any person as a person of a sound mind. Yun ang default natin. Okay. Next slide, please. So, judicial intervention is a remedy, But we don't often resort to that, Physicians make the de facto determination na competent ito, saka hindi competent, And one disadvantage of judicial intervention is it involves delay, Magpa-file ka pa, it's a set up for hearing, etc., etc. But this is a remedy, judicial intervention. I still have to see a case here in our jurisdiction in the Philippines addressing the capacity of patient to make a decision. Next slide. So what happens if a patient is a minor? The father and the mother shall jointly exercise parental authority. When the father and the mother disagrees with the treatment modality or the intervention, the father's decision shall prevail. Yan po ang ating batas sa kasalukuyan. It might sound unequal, bakit yung father. But that's the law. Dura lex sed lex lang po tayo. In case of absence of either parent, take note that the law states absence or death. In other words, you don't need to convene the two parents to make a decision. Yung parent present lang po, pwede na yon to make a decision. In case of separation of the parents, parental authority shall be exercised by the parent designated by the court. Okay, next slide. what if there is a surviving parent, ano? Nag-asawa po ulit ito, yung parental authority will not be affected, doon sa children. So, that's why I always tell doctors, take time to read the personal information ng inyong mga pasyente, their parents, their civil status, because that's important when it comes to informed consent. Then, in case of death of both parents, surviving grandparents, what if the patient is an illegitimate child, Mother alone can make that decision, Yung pong choice of a minor, let's say over 7 years old. Do I have to consult or to ask? Under our current jurisprudence, when it comes to a legitimate child, the concept of giving the choice to a minor does not apply. No, that's the state of the law. Okay, next slide, please. Substituted parental, nawala lahat. Surviving grandparent, oldest brother, child custodian. The problem with our case is children yun, children yung nandoon. And next slide, and this will be the one that is applicable, The problem is, yung pong brother or sisters, or son or daughter, ito ang sa atin, ito yung son or daughter. Wala pong sinabi ang ating batas who shall be the decision maker. Wala pong sinabing yung panganay. Basta ang sabi sa batas, son or daughter. In our case, nagkaroon ng pagtatalo. Yung isa, yung bunso, doktor, siya nagdi-decision, sige, pa-operahan. But, I think in our case, medyo nagkaroon lang ng, siguro, nagkaroon lang ng glitch because as far as I'm concerned, the information is very clear. We have a competent patient, But she deferred it as part of her autonomy. She deferred. Tanungin po yung aking mga anak, And it further became complicated because hindi nagka-agree. But eventually, nag-agree. Next slide, please. How about common law? Again, this is the state of the law. A common law partner does not enjoy that surrogate decision maker status compared to a married couple, yung asawa pag naging incompetent. Hindi po nagko-convert yun dahil siya ang common law, yun din pa rin pong parents or siblings ng lalaki or babae, Unlike when it comes to a lawfully married individual, yung asawa takes over. Sa common law po, hindi ganun binibigay. However, in some occasion, the common law partner may act as a guardian. Recognized naman po yun ang batas, as a guardian at the time of the incapacity or absence of immediate family member. So, I think this will be my last slide. So my final comment here in our case is we have a competent patient here. And although medyo hindi niya ina-assert yung kanyang authority to make the decision of a competent individual, he opted to refer it to the children. Unfortunately, nagkaroon ng di pagkakaintindihan initially, but eventually the patient or the children agreed to have their mother undergo the operation. So, final comment ko dito, that autonomy involves her decision to refer the decision maker to the rest of the family, or family members, yung mga anak niya. yan ang Pinoy. But actually, in law, kasama yun sa autonomy, I am competent, but gusto ko po i-refer pa rin yan sa mga anak ko, sa family ko, sa asawa ko, and so forth. And that's the coverage, at least from the legal standpoint, ng doctrine of informed consent. Thank you.
Thank you, Dr. Kapule. That was quite an extensive lecture on informed consent, and you're right that in informed consent document can still be questioned. It's a process. It's a process rather than just a form. And if the what you said, the determination of the process when they sign, it could be that. And even in court, there should be some evidence that the informed consent form that was signed should have some other evidence of how the informed consent was obtained. So we got that from the lecture. So thank you very much. And one of the things that we learned also is that when a competent patient wants to share the informed consent with the relatives, it's part of their autonomy to get the relatives to be part of our institution. So thank you for that, Dr. Kapule. We shall now call on Dr. Moral to have your comment. Dr. Moral.
Right. Thank you, Dr. Damaso. Again, thank you for inviting me once again. It's been a while, and I'm glad to be back. But anyway, let me start off by saying that although it's a specific case that is the jump-off point for the discussion of informed consent, I always say that we have to individualize or personalize the case in itself. So in terms of focusing for informed consent, let's tackle the fact that this is an 88-year-old female patient with dementia. The terminologies will always be important in labeling this patient rather than as a demented patient or a patient, intestinal obstruction patient, by starting off with the term that it is a patient with dementia and an obstructed bowel. Because it starts off by considering this as an individual patient. One of the key reminders that I always mention is that we have to be careful about stereotyping because it's an 88-year-old patient, so it's an older patient, and that's a patient with dementia. Now, it's been mentioned already earlier by Attorney Dr. Kapule about looking at the patient's capacity to make decisions. So not because a patient is demented or has dementia may make the patient unable to make decisions. Because if you ask the question to the patient and the patient has the same opinion during all the lucid intervals, then the patient has decision-making capacity, first and foremost. And second is that we have to look at things in terms of an infiltrated aspect. It's been mentioned that in terms of the Asian setting, although autonomy is a very Western concept, in the Asian setting, it's a communal concept. That means decisions are arrived by the community. And when we answer, it's based on context. I'm sure you've had this many times. So if someone has asked, kumain ka na ba? Ang sagot is busog na ako. It's not answered by yes or no. So it means you infer the conversation that yes, I've eaten because I'm already full. And we have to be careful in terms of our conversations with our Filipino patients in that way. That answers may never be direct, and in fact, they may be contextual. So in terms of the decision-making process, you've been presented the idea format. We always say there's an easy approach also to look at medical indications first and foremost, followed by patient preferences, followed by quality of life, and then by contextual features. So in this particular case, we have an 88-year-old patient who has again premorbid. The patient was still functional, even with a TIA premorbid. The following thing is that what is the preference? So this patient apparently refuses a procedure. So what do we do with refusals? This was mentioned earlier in the talk. So you have to consider the procedures. If this is a low risk, it's a low risk procedure, but it's life-saving, we really have to seriously look at the patient's ability to make decisions. So this is a low risk and life-saving. But if it's a high risk and life-saving procedure, this is where we may really have to look at the discussions in terms of whether these risks are acceptable. And these will be the challenges of looking at it. So what do we do when a patient refuses? As we said, it's not automatic to accept the refusal. The first thing to do is ask why. Why are they refusing? After a patient answers that, we can mention now the consequences of the refusal. Because sometimes when they understand the consequences of the refusal, they now agree. If they still do not agree, we try to convince them. Again, mentioned earlier, not to scare them, but convince them of the benefits. Like this patient, although the patient is elderly, has a good premorbid, this may be totally life-saving, and the patient can still have a good functional status afterwards. However, if they still refuse that, then we go now to acceptance, that we accept the decision. But remember that a decision to refuse is not always absolute. In this case, it's not emergent, we may ask again, and there may be a change in decision making. Now, the other aspect of decision making here, or informed consent, that is problematic here is that we now have children, and as you said, decision making in the Philippine setting is communal. It involves a family, and you have one child who disagrees with the decision of the parent, and the other three agree. The thing is, we don't really work on majority. Most of the times, it will be the one who's paying for the bill. That will be the sibling who pays for the bill may make the decisions. What is the best way of resolving things? One of the things we've recognized, I'll give an update at this informed consent, is that the use of technology has actually accentuated the way we get consent, especially if there are children who are not present in the Philippines or are present abroad. Because we're now able to bring them into the fold of the discussions. So family meetings have become important. Maybe for the purposes of time, you may actually look down an article on using telemedicine for family meetings and informed consent and even breaking news. So you have a certain spikes protocol that you can actually use via telemedicine. But what's important with using this, for example, getting everyone on board for the discussion makes everyone on the same page regarding the discussion. I don't know if you're aware of the daughter from California syndrome. Have you heard of that? I discussed this in the PCP plenary before. The daughter from California syndrome means it may be a detached relative who is now participating actively in the decision making regarding a family member and may not be as actively participating. What we've seen is that with telemedicine, because they now see the actual face of the physician, let's say it's a sibling or living abroad or away, they can actually see the face of the physician. The conversation becomes actually more personal, even if it's done by technology. And it allows now a better understanding. So coming to a common agreement is actually much easier, and it can be facilitated. Of course, the face-to-face encounters and discussions will still be the best. However, we can use now technology to augment this in terms of securing the consent. So as we saw in this particular case, what happened was the patient eventually agreed along with the family, and we had a good outcome. Obviously, this will not always turn out to be the case, but I think it's important to understand that in informed consent process, although we look at autonomy, we also have, as we said, beneficence. And these two principles can go in opposition to one another, like in this particular case. The way of resolving this is, of course, looking at the features that will be important to the patient and the family. And if the patient does accept the decision, does accept the suggested procedure, then we proceed with it. If they refuse, we have to go through a process before we accept it. Now, my apologies. Now, as I age, I keep forgetting things. There was something I wanted to mention which is important. Never mind. I may remember it in a while, so just in case I remember it, I will mention it in a bit. But hopefully that will be my short contribution in terms of the ethical aspects. Do remember that although we have principles, again, as I said, you have to personalize it. Apply it to the case, looking at the other contextual features which will be important to the decision making. Thank you, everyone, and thank you, Dr. Damas.
Thank you very much, Patrick, and zero on to this statement. I will open the discussion to our audience, but let's start with something like for both of you. We were talking about informed consent autonomy, but there's also the hierarchy of proxies. We have ethical proxies, we have legal proxies, and so forth. And so when we're talking about dementia, and we're doubting if this patient can really give a very good informed consent, and we talk about proxies, what happens when it happens if there's a disagreement? Will you use the definition of a legal proxy as the one who can make the decision, or the one who is ethical proxy in this part? to make the decision on in this situation? Or would you still go on the what we call shared decision, or will you go on the paternalism type that the doctor knows best? How will you approach situations like that? Dr. Kapule first.
Oh, okay. Very common. That's a very common problem when it comes to, when one is taking over. In fact, again, in our culture, paternalism exists. Kung sino yung panganay, we have to defer. Kung panganay, But sometimes I have occasions to witness that the decision of the panganay or the eldest is not really the best one. And if that's the case, I would go for the same remedy, As I mentioned in my slides, you again explain, as mentioned by Dr. Patrick, it's not simply accepting, yun ang decision, tama na yun, okay na yun, may decision na yun, From the ethical standpoint, we are admonished to go back, explain again, these are the pros and cons, And doctors sometimes are very, very notorious, when it comes to spending time with doctors and family. In one study done many years ago, in a 24-hour period, admitted patient, the doctor spent, mind you, 3 minutes to 15 minutes for 24 hours. That's my basis yung occasion na yun. We don't spend so much time. And when it comes to informed consent, that further highlights the accusation, We often, ayaw okay. The end na, ang discussion, ayaw But we are advised from the ethical standpoint to go back, ask why, bakit po ba yung decision, especially if really the recommended procedure is life-saving, Perhaps it's high time for us doctors to erase that notoriety, na hindi natin pinaglalaban yung best interest, And sometimes, as I've said before, minsan, Dr. Patrick, yung paternalism, magandang, naman yan, purpose sometimes, doon natin nilalabas yun, the situation that the decision really, when it comes to a life-saving procedure, seems to be abandoned by the surrogate decision maker. Doon natin paglalaban yan. But again, in very consistent naman ng court cases, pag talagang ayaw, you have exhaust everything, then that's it, We really have to respect the autonomy, And when it comes to decision maker, in other words, hindi competent by law kasi wala tayong magagawa na doon. Unless we want to seek a judicial intervention, which is very expensive, the delay is there, and by the time the court decides, anin pa daw yung damo, Wala na yung kabayo, So that might be an extreme scenario, but that's a reality. Ang point ko lang po, sir, doon sa tanong niyo, we don't just stop processing, or going into the decision-making process, informed consent process, just because there was a person who said, ayaw namin. There's no harm, again, going to the same process of informed consent. Thank you.
I'd like to thank Atty. Kapule for jogging my memory. I remember now what I wanted to say earlier, so before I respond. Normally, what we do sometimes is we offer buffet options to the patient. And it's very difficult for patients and family members to process the buffet. That's why you always have to mention what is your suggestion that is best for the patient first, before giving the alternatives. And remember, one of the alternatives is doing nothing. But always emphasize that doing nothing will carry with it certain complications too. So we have to really emphasize what we consider the best for them to consider that as an option. Now, what do we do with family members? I'm very proactive now in most of my patients. That's why the first time I meet them after the rapport, for the second consult, I usually ask them, who helps you make decisions? Because at least that now gets them to identify Because as they progress in age and with disease, I'd like them to really assign a health proxy, someone who can really help them make decisions. For example, in my setting, I have a legal document that assigns my sister as my health proxy. So it becomes very definitive. I do have a lot of patients who are same-gendered partners who are actually estranged from family. So if you follow the legal case, right, attorney, we will follow their family members because this is similar to common law partners. They are not the partners, but they may actually know what the patient truly wants. So I do think there has to be at least that legal basis for that in order for that to be respected. And to make sure that the decisions carried out for them are what they truly want.
If I may
Right?
add something, Doctor, now that Dr. Patrick mentioned it, one way of setting aside the hierarchy in our family tradition is to assign really a person. If you can present ito po, notarize po yung mga proxy na yan. Wala na tayong pagtatalunan doon sa sino ba, sa panganay ba, yung bang nagbabayad, yung bang nasa abroad, etc., etc. That's one way of skirting the legal requirement that we defer to the family members. Yun lang po, Doctor. Thank you.
Thank you, thank you. So now we can invite comments from the audience. Probably we can start from our masters, those who graduated. Can we shoot back the question? Yes. You know, this is a matter of informed consent, and there is no agreement among the siblings. And there is a problem there. Can you comment on the best, probably the best way is the shared decision? That's what we want, right? Shared decision making and getting the consensus and getting the best option. In this case, you don't have the shared decision. You dissent. How do you deal with this? Can I ask some of those of our graduates? Can I ask Dr. Cordero? Let's start with you.
Yes, thank you very much, Dr. Damaso. Yeah, so this is an informed consent and autonomy issue. But speaking as a surgeon, I think I would really try to convince the patient to undergo the operation, because there are some diseases that can only be relieved surgically. That's why there are surgeons. Because most of the patients will ask, can we have some medicine for that? And that's it. I mean, I cannot abandon this patient just because that's the common default, as Dr. Attorney Capulo said. Ayaw, papirmahan mo, refusal, or dama, or against medical advice. But it's not practicing the principle of beneficence, because for this particular case, as a surgeon, I know that that's the only thing that can save her life, to do surgery. So if I'm going to wash my hands, because that's the usual default position of physicians, ayaw. So wash my hands, let the patient sign, and what will happen to the patient? So for those who are trainees, we should make a stand. As my training officer will always say, stick your neck out, because this is for your patient and not for anybody else. That's all. Thank
When
you.
you say that, Joseph, stick your head out.
Stick your neck out.
Stick your head out. You mean say you're going to use methods to do that, like paternalism? You use authority to be able to carry it out, or what do you mean by stick your head out?
Yeah, to stick your neck out is to make a stand. as Dr. Moral also mentioned, no, you cannot just offer a buffet. You should always give the best. This is the best treatment, the best outcome. For this particular case, it's hernia surgery and nothing else. No? And to stick my neck out is to make a stand and for the benefit of the patient. That's it. No? Because I cannot wash my hands because I cannot get a consent. As Ina mentioned, we can practice selective paternalism because since time immemorial, it's really the doctors who knows
Yes.
best. No? It's just recently
You don't get
because of
you
what
don't
happened.
get that, if you don't get the consent. You don't get the consent, and you say you cannot afford that. Will second best be okay?
Well, the second best for this particular case is well, TPN and wait if the hernia will resolve or the obstruction will resolve. But for an obstruction case, as the aphorism will say, no? Especially for complete obstruction, you cannot let the sun set or rise for a complete obstruction. But for this case, it's just partial. Yeah. As a surgeon, I will really say that well, this is the only option. The second best, well, as the name says, it's second best, and probably the patient will die. That's it. Thank you, doctor.
Thank you. So can I get any more comments from the others? If not, one thing like in these surgical conditions like this, suspected obstruction, the pain, and all, and there's an initial refusal for surgery, you know that the condition is not static. The condition waxes and wanes. It can get worse or it can get easier. So this movement, I'd like to ask, I'd like to direct this to Dr. Johnny King. If you're there. So the condition is not static, it's mobile. Is it right to just sit down and then wait for them to really feel it? If that's so bad, if that's so worse, that they have nothing to do but to subject themselves to what you're saying?
Good afternoon, everyone. Thank you, Dr. Damaso. I believe that the physician must not be a passive participant in this case, and this is where paternalism will come in because it is inherent in the role of physicians. So we don't just and we do not when you respect patients' autonomy, it doesn't mean that you have to abdicate your professional responsibility to your patient. So this is where you have to keep on trying to have productive dialogue with the family, with the patient, so that you're able to really protect the best interest of the patient. But then, if I was wondering, because this patient, though has dementia, has decision-making capacity. So for me, it would not be problematic. You just respect the patient doesn't want, but that's not the way to go. You have children who are very much involved in the decision-making process, and this is where we have to, like Dr. Moral has said, this is where we engage the whole family to make a decision. So that's my point, no?
So this is one point where you think paternalism would work.
Yes, doctor. Yes, especially in the context of a Filipino family, where even if the patient has already made a decision, and the children are there, with conflicting opinions, I think it would still matter to them because the decision of the family is valuable to the patient. So you have to bring everyone, and of course, hopefully, you are able to come up with a good decision for the patient. The problem is when you're not able, and this is time pressured. We have an impending what do you call that, hernia, obstruction, whatever. So we cannot wait forever to make a decision. Eventually, we'll have to come up, and sometimes this is where paternalism will come in.
So going back to the idea of paternalism, and I give this to Dr. Mural. Certainly, it was much easier before when paternalism was operant and the doctors knew well, and the doctors had a heart anyway to really serve the patient. So in cases like this, when paternalism was rampant and operant, it was so much easier. But now that we've changed everything and informed consent and autonomy reigns supreme over paternalism. So what you say, and now John says that it's nice to go to that level in some cases like this. It would really have helped if paternalism was used in our decision making for this way. Are we allowed to do that shift now?
But I think one reason why we moved away from paternalism was that if the doctor made all the decisions and was the one who determined what was best, if something went wrong and you were brought to court, since you were the only one participating in the decision making, that would be problematic. That's why we moved towards a model that's a shared decision making because it respects patient autonomy. I think when we talk about paternalism here, we can be paternalistic in the sense of what is the medical treatment of choice, because we will really be the authority to determine what treatment of choice would be there. But now, when we infuse the decision-making of the family with, as we said, contextual features, quality of life, and preferences, that's when things change. So I think we should be paternalistic in what we recommend to them as the best option, because that is based on all the medical indications and what would benefit the patient. However, as we said, at the end of the day, we have to infuse that decision with what's important. Because sometimes, I'll give an example. We had one patient before who had severe anxiety disorder. She could not decide on resecting a tumor, a bowel, a colonic tumor. And that would be resectable, very resectable. So she was rendered by the psychiatrist as psychologically incapable of making decisions. So we had to bring it to legal and everything else. She was operated on. She survived for another 10 years. She did not actually take it against us because that was found, and she died from another illness. So, as we said, you have to exert a degree of paternalism in terms of what you think would be best for the patient, but never disregarding, as we said, the contextual features beyond it, as well as preferences and quality of life.
Thank you.
May I, Doctor?
I could see you wanting to react. Please.
Going back to your question po na yung bang second best is acceptable. I used to think as a student that if I don't give the first drug of choice, I'll be committing a mortal sin. That was my thinking in medical school days, because in-emphasize sa lecture and first drug of choice, second drug of choice, third drug of choice. But when I went into practice, hindi naman pala ganun yun. Okay, then addressing our issue. If you are left with a card that this will be the second best, it's still ethical from my end, because given factoring in the fluidity of the situation, I'll still do what is best. It might be the second best, but given the refusal, then I am left with the second best. And I think it is still within the context of the 4 pillars of bioethics. If we go for the second best, paano ayaw talaga, then I'll do. And also, sabi nga ni Dr. Joseph, mere refusal will not compel me to abandon the best interest mode of my practice as the attending physician. I'll still do what is best for the patient, except that, you are left with this refusal, then I'll go for the second best.
Dr. Kukure, I'll give you background because why I asked this question. We do a lot of multidisciplinary consult with cancer patient, what to do, what is the best thing to do. And we have there the experts, the radiologists, the radiotherapists, the chemotherapists, the internists, etc. And then we discuss what is best for this cancer patient. And then when it's all laid down to the patient says, no, I really cannot afford that. Is there any other second best? And then when we offer the second best, that's the one that can be afforded. And I think it's really very ethical. That's the only alternative that can be done, and that's what we can do. On that aspect of second best, it's without problem. I think it's ethical to offer that what is possible. You cannot, force them to go to Stanford and do the surgery, etc. It will be not
Dr. Ramason?
yes.
Yeah, maybe in terms of that, if you look at the cycle of communication with patients, in terms of the clinical encounter from preparation to closure, there's a part there that actually works with negotiation. That means negotiation means if you don't go with the first option, you go for the second option. However, you always have to manage expectations because you're not doing the optimal procedure, you manage expectations. And again, for example, if you're quoting, for example, financial expenses and everything, this is where you now bring out the virtue of altruism on the part of the doctor, that you may have to transfer them to another hospital where they can maximize their expenses. But this is actually beyond even what is expected of us. But it's something you can manifest as a kind and good doctor. So maybe importantly, managing when you negotiate, also manage expectations. Baka you might say second choice, but they expect exactly the same results as the first one. So always make sure you manage expectations.
Almost the same department with the second job. Thank you. Now, can we call on some other, the other masters there? Can I call on Dr. Alvia? Are you there, Dr. Alvia? Is Dr. Alvia there?
Yes, doctor.
Dr. Alvia, you know this case.
Good afternoon. Yes, doctor.
You know this case. Let's go
Yes,
back.
doctor.
Let's go back to this case. Where would you position yourself in this case if you were the relative? Would you be the one who's against or the one who would go with the and
Doctor, if I'm the relative of the patient, of course I would want what's best for the patient. But as a daughter, especially if I were not a doctor also, but as a lay doctor, I'd also just want to make sure that my mom will be okay, because of course it's a surgical procedure, and I think that's the one that we always have to consider when we're recommending surgery, especially to senior patients, that they'll be okay. So of course we don't give them that 100%, so that as Dr. Oral said, we can be so we manage expectations. Now and more so if I'm the doctor, I would also explain both to the mother, the patient, and also to the siblings that doesn't the pros and cons of the procedure, and then the reason why it's important that the patient undergo the procedure. I'd like to add with regard to autonomy versus paternalism. I think we can these things can meet in a family discussion, that the doctor will really have to sit down with the patient and the children, because with a family conference, I think that the patient and children will feel the intention, the good intention of the doctor. And this is how you will, quote unquote, win them over. And they will realize and understand that your intention is for the good of the patient and not to do harm. That's all, doctor. Thank you.
Thank you. We still have other master on there. Elaine, are you there? Dr. Araneta?
Just on leave for
What about si Dr. Quintanar? Hello, Dr. Quintanar, you're there?
Yes,
So the question that I ask you is, what's the end point the ethics committee told them the best thing is discuss again with the patient and give the information. And we know that the situation is not static, it's mobile, and things are changing, and therefore new information will be given to them. And so therefore, constant communication with the family is very important. What do you think is the endpoint?
Doctor, first I'd like to thank the two reactors, si Dr. Attorney Capule and Dr. Patrick Moral, for the learning process that we just had today. In this case, I think, as has been narrated or verbalized by all the speakers, we have to do what is good for the patient. So we apply several principles. One would be the principle of moral discernment, which is to discern and decide what is good for the patient. And of course, connected to that would be the principle of beneficence, and of course also the principle of the respect for the dignity of life. So it is incumbent on me to try to my best to convince the patient to have surgery simply because it will do good in saving her life, for her to undergo the procedure. Now, I have a question for everybody, probably to learn more about this case, which is to ask the presenter, our resident presenter. It wasn't really explained, but I would like to find out what is it in that informed consent that led to the patient saying that she does not agree to the surgery, and which also resulted in 3 out of 4 children deciding that they agree not to have the surgery. What is it that the patient said that led to this decision? And the second question to that is, what is it in your process of informed consent that led the patient to change her mind? Emphasizing the process of the informed consent is a continuous process. And from that, I think we can learn more. Dr. Dennis.
Okay. And when the resident comment on that, what made them change their mind?
Okay, so the patient didn't want to undergo the procedure because she didn't experience any pain at that time significant enough to undergo the procedure. For her, it was tolerable, and that she was really insistent at the time po to na po. So that is why she refused to undergo the procedure at that time. And then what made her decide to finally undergo the procedure? I think she was the children of the patient somehow talked to her or explained to her why it is necessary to be operated on there po. And then with regards to the 3 out of the 4 children, the background of the decision-making process, that's 2021 where she underwent the hip replacement surgery. It was that one child who signed the consent for her, and at the time, since then, the mother was somehow blaming the child for why did you consent for the surgery for me? I didn't want to undergo the hip replacement 2 years ago. So that child from then on said that okay, just let her decide on her own. I don't want to be involved in the decision making process of my mother. So yun po yung parang naging background ng story ng children, between the children and the mother po.
So what you're saying is that there was an agreement to operate her, because the children change their mind and they talk to the mother, and the mother agrees for the surgery occurred.
The three children po, doctor, they, first they didn't completely disagree with the procedure. They just didn't want to be, in the way, or they wanted their mother to decide on her own.
By the surgery, the mother changed her mind.
The mother, yes po. Eventually, the patient changed her mind. She eventually consented na po for to undergo the procedure.
Now, after all has been stated, and it's a question of important question. As a surgeon, I'd like to ask. You were talking here about an inguinal hernia, and then we're talking about obstruction. Why would this inguinal hernia cause obstruction? Was it incarcerated?
Yes, doctor. It was beginning to be strangulated na po actually.
You were not able to reduce it?
No po, doctor. It wasn't reducible.
But I thought in your PE, you look at your PE, that there was a defect down there. Therefore, it emerged.
There was already before the 6th hospital stay. There were no signs of strangulation yet.
But it was bulging. No, because your PE didn't show the bulging. Your PE just showed the there's a defect.
There was a prominent hernia na po at that time, doctor.
So this patient had an incarcerated.
Yes, doctor.
So any questions? Anything? Yeah. From the Q&A, what I get is congratulations to the master graduates. We'd like to any questions today. So we don't have any questions from the audience. Oh, here. Somebody raising his hand. But I cannot get it here. Yes, anybody? So we will congratulatory notes here. So if there are no more questions, we will ask the head of the Bioethics Committee to, well, if there would be no more questions, we will close this with the open forum. So we will award the certificates. We'll ask Dr. Valentin to award the certificates.
For that kind introduction and for agreeing to moderate this afternoon's bioethics grand rounds by surgery. Special thanks also to Dr. Capule and Dr. Patrick Moral for gracing this occasion, and to our resident, Ina Gutierrez. Surgery has a lot of cases today because we lack residents. Some are on leave, on maternity leave, and well, thanks be to God, we've accomplished it. Thank you, Ina. Just a disclosure, this is actually my patient. So after sitting in the Bioethics Committee for almost 2 decades, just this year, I have to be on the other side of the fence and to sit an ethics consult. And it's not easy, so I now understand our colleagues who have to seek an ethics consult in our committee. And thanks be to God, this another disclosure. This patient is a mother of a doctor, so the daughter is actually a doctor, a colleague of mine, not there in Makati, but in the hospital na Makati. So she's more senior than I, but she's a classmate of some of the attending. So yeah, special thanks to the ethics committee when I did the ethics consult, and I was really enlightened on what to do, because as a surgeon and a member of the bioethics committee, it's very distressing to have this kind of case, no, fall on my lap. So thanks be to God, no, that Makati Med has an ethics committee manned by very knowledgeable and ethical doctors, no, led by Dr. Damaso there, and as a not so young surgeon, but still young in terms of surgical knowledge. No, this will be. I'm on my third decade as a surgeon, but there's still these cases that I have to meet, and also one thing that helped me here was I called a senior surgeon of our department, in the person of Dr. Tony Macapagal, no? And this was not a very easy case, no, because we have to dissect. So although the patient's bowel was not frankly gangrenous, but it was strictured. No? So after a few minutes of waiting, it became pink, and but if I was the one just scrubbed, no, I wouldn't have resected it. Thank you for the senior surgeon. He said that he has experienced something like this, and if you do not resect, it will just obstruct in a few days. So, because even though she's 88, we did a resection. So, I hope some of our physician residents and even our colleagues learned something from this case, which is very close to my heart, because I was the attendee. So thank you very much, and thanks be to God that we are in Makati Med with very ethical surgeons and physicians. That's all. Thank you.
Thank you, Joseph, and thank you, everybody. But before we end that, I think we also owe some thanks to Dr. Ivan Gutierrez. Alone, a first-year resident is able to handle and discuss this case. I was asking for some more senior support, but they're all busy in the operating room now. So, congratulations and thank you. So with that, we will end this.